approach. They are a nonprofit that exists exclusively upon the kindness of strangers. And for 33, I know it was close. For 33 years, they've been providing this wonderful support in Houston and other communities across the country. So I urge you to go pick up a squeezy toy from them, and yeah, your cat or dog will probably destroy it. I'm sorry, but they're good people, and I appreciate the fact that they're here today. So we have talked a bunch about the new stuff that's percolating up in the world of CLL. We have talked about how we're not big fans of watching and waiting and winning and worrying and all that good stuff. Let's get to the point where we're past watch and wait. I'm going to start off with you, Dr. Bill. We're now treating the patients. Some of these treatment protocols do have side effects and they do show up. How and when and what to communicate to the healthcare team? What information do you need to help mitigate what can be unpleasantness in CLL treatment?
That's a tough question. I mean, I think all of the treatments that we use, each of them have their own set of side effects and toxicities that we see more commonly than others. And sometimes there are rare things that we don't commonly see, even if we see a lot of CLL patients on a particular treatment. So, I mean, I think letting your care team know what's happening, what's new, what's uncomfortable and concerning to you is important. And talking to your physician about that. It's hard to say if there's anything in particular, because each of the treatments have their own set of toxicities. And so we look for different things depending on the treatment that patients are on. But as I mentioned earlier, most of these treatments are very well tolerated by patients. And much better tolerated than chemotherapy was.
Chemo, from everything that I experienced watching other people go through it, was not a pleasant experience. I know that when I went through my clinical trial, which was only a monoclonal antibody, my first day was not the suggested 6 hours of you're going to have a few bumps. It was a full day of unpleasantness.
Yep.
Why is it that so many of these treatment protocols have a bad first day? What's going on? What causes people to have all those bumps?
So, well, I think what you're referring to is mostly the CD20 antibodies is what we see, what's called the first infusion reaction.
Okay.
That's there is an immune component to it, where you're getting a monoclonal antibody that binds to your leukemia cells, and there are chemical messengers that are produced in your body. You get fever, you get shortness of breath. The higher the white blood cell count, the more severe those reactions tend to be. And so it's sort of an immune reaction from the infusion itself that quiets down when the infusion finishes. And sometimes people have a little bit of fever a day or two after their infusion. Because there's not as much leukemia there for the second infusion, those reactions are much less.
Gotcha.
And also we try to pre-medicate patients liberally with steroids to mitigate those, although we can't always achieve that with steroids. But the subsequent infusions are less severe usually because there's less disease.
So you brought this up earlier. I'm going to now move to Dr. Lamanna. We're going to be talking about secondary cancers or associated conditions that I should be aware of. Last night, I believe we threw up the C word, comorbidities. And everybody here knows, and everybody online knows, you're supposed to be taking care of your own comorbidities, right? I mean, I need some affirmation here, nodding. Yes, you're taking care of it. One of the things that's batted around a lot on the support groups is that CLL patients should be seen by dermatologists regularly. What's going on there?
Yeah, I mean, as we talked about earlier, because of your immune dysfunction, right? Your immune system isn't as good. Your body's ability to surveil and prevent other things from happening is not as good as well. And so in addition to the infection stuff, which we talked about earlier, this can also play a role with the increased risk of other cancers. So you're, normally all of us on each day are bombarded by different environmental stimuli and different things in addition to our maybe perhaps genetic components as well. But if you have CLL, your immune system to fight off some of these cancers or some of these conditions are more impaired. And so your body's ability to overcome them is dampened. And so there's no doubt there's an increased risk of other cancers. And skin cancers are one of the most common things we see in CLL patients, mostly basal and squamous, although there could be melanomas as well. And so we always recommend, again, when we talk about preventative strategies or other cancers can be curative, right? So you find something early, they can remove it. And so dermatology is one of those things that we say, please, once a year, if the dermatologist is following something, they'll tell you if they want you more frequently, listen to what they say, but at a minimum once a year, so that if they find something early, they remove it, they send it for pathology. And that's why we recommend all the generals, not just for dermatology, but other routine cancers as well.
So when should CLL patients be getting their colonoscopies?
That is still, unless they have a family history, then now the age is, I think, shifted a bit, right? It's now 45, it used to be 50. So typically we'll tell people to get their screening. Now, if you have polyps, right? So the point of the colonoscopy is to try to catch those polyps because there is a lag time for most individuals when polyps could turn into a malignancy. The goal is if they find those polyps, they remove it. Generally speaking, if you have polyps, they'll probably tell you to come a little sooner to get another repeat colonoscopy, rather than 5 to 10 years. They might say, hey, I want you to do it in 2 to 3 years because you had some polyps. If you're clean, they'll probably say, no, you're good to go for 5 to 10 years. I say 5 to 10 years because they switched the guidelines on that too. I encourage my patients probably to do it a little sooner. The guidelines have shifted it to 10 years if you're clean. I'm like, yeah, let's talk about it again in 5 years. But if you have polyps, for sure, they're going to want to do you sooner. And again, the goal is to try to catch those polyps early and remove them so that you don't have a problem for them. So that we do recommend age-appropriate guidelines in general for the other cancers. Again, with your mammas, your paps. After, obviously, for folks who are much older, comes a point in time where we'll go, great, your utility of screening and have a colonoscopy at 85 we're probably going to say no, unless, again, you're high risk for a particular reason, or you have a lot of polyps. Otherwise, now, there's also tests that look at the DNA in the stool. So you hear these commercials like Cologuard and others. I think there's more than just Cologuard. Well, they'll say you could, take and send a stool test. And so for patients who have clean colonoscopies and are of an older age or may have issues to even have, perhaps doing a colonoscopy might be contraindicated for other reasons. There is other ways to screen people. So we encourage you to talk to your docs about those too.
Are there any other conditions that CLL patients should be aware of other than the standard cardiac issues, high blood pressure, diabetes? What else should we be looking at? Are we more susceptible to something else?
Well, we could do a whole list. Do you want to go or you want me to go?
I'll talk a little more.
Yeah.
So other things to think about are the secondary cancers associated with treatment. So for patients who have gotten prior chemoimmunotherapy, specifically with fludarabine or bendamustine, there is a risk of secondary myeloid leukemias that we have to watch out for. So that's why it's also important not to stop following with your CLL doctor. So even if your counts are all normal and everything's fine, you should still see a hematologist long-term to just monitor for that. And that's just gonna be a simple blood count. Other things that are associated with CLL include autoimmune complications. So most often the autoimmune complications coincide with progressive disease. So that's something that we kind of follow. But the autoimmune complications, include autoimmune hemolytic anemia and immune thrombocytopenia, or IHA or ITP. So those are other things that we just have to watch out for as well.
Interesting. Dr. Jackie, we talk a lot about getting a CLL specialist.
Yes.
I'm already a believer. I have a CLL specialist on my team. How do people get a CLL specialist? What if you don't live in Houston? What if you don't live in a big city? How do you get a CLL specialist?
Well, excuse me. You can always go to the LLS site. You can, talk with your local oncologist, whether they are CLL specialists or not, and they may be able to to point you to in the right direction or refer you to someone. There's all types of listings on the internet where you can look up those things, particularly within certain hospital systems. And then there's always MD Anderson's website where you can find CLL specialists. So many times patients are sent from the community. Many of them are seeing themselves different advertisement on TV now for all the MD Anderson institutes that are going up. And so they're, you can always look it up or have your physician contact someone who is a CLS specialist. However, let me reiterate the importance of having you need to have a CLL specialist. If you come into Houston and we initiate you on therapy and say you're doing well and we don't need to see you as frequently, but when you go back to your local areas, you need to have a specialist there, even just an oncologist in some cases, because sometimes you can have things or complications that may happen down the road, and your primary care doctor is not going to know how to manage those. So that becomes very important. If you don't understand the disease process, it's difficult to understand how to manage side effects, maybe from treatments, or it may not be acute side effects. It may be something that happens down the road, but you just need someone with that knowledge to be able to manage that. Just this week, I had a patient call, and they were having some side effects. And they said, well, what do you want me to do? I mean, they told me, they went to their local oncologist. They said, well, you need to call your doctors who are treating you. So the problem lies in that if you're living out of town or out of state and we are here, we can examine you to make the appropriate choices of how to intervene with that. So you need somebody that's knowledgeable enough to know, how to manage these things.
It's important stuff. I'd also like to give a shout out to the CLL Society. They have an Ask the Expert program that's available online.
Right.
And if you're having difficulty finding a CLL specialist in your backyard, it is a great place to start. Virtual medicine, telemedicine has created opportunities for all of us that didn't exist before COVID. And so you should absolutely take every advantage that you possibly can to get a CLL specialist on your team.
Right.
So we've got a bunch of CLL specialists here, and they've told you about all of this wonderful new stuff that's in the pipeline and coming down the pipeline, and it's stuff that's already here. Dr. Wierda, how much does this stuff cost?
A lot of money.
See,
You gave me that
I
question.
went there.
MD Anderson's very rich though, so.
The new treatments are very expensive. That's without question. They're very expensive, and most patients with CLL are in the Medicare age category, and not all of them have a supplemental. So Medicare pays for 80%. 20% doesn't sound like a lot, but if you're talking about $10,000, $12,000, $15,000 a month total, 20% is a lot of money, particularly for patients on fixed income. There are a lot of patient assistance programs. Those costs that we talk about are not really the costs of drugs. We talked about this last night, or really the amount of money that gets paid for the drugs. So I think probably the best recommendation sort of to navigate that whole process is to work with your care team, work with your mid-level providers or the pharmacists to help with patient assistance programs and those opportunities that we have for patients to get the treatments that they need. There are a lot of them out there. You just have to investigate and look for them.
Dr. Lamanna, would you like to add something to that?
Yeah, I mean, usually when we're about to initiate a therapy for a patient, we will initiate that process on their behalf. So we'll initiate the copay process where we'll prescribe and then see A, if their insurance approves the medicine, and B, what their copay is ultimately for the drug. And then before that even happens, then, we're talking, we get that response back literally within a few days. And, we'll sit down and then talk about if we're going to go forward on a particular treatment based on that information. If there seems like there's a hiccup, because there is a large copay, they reach out, then the pharmacy team lets me know right away. And then they reach out to the patient to see if they'll apply on the patient's behalf to these assistance programs to see if they can get a reduction in the copay. So we don't start anything until we know. And that we've all agreed upon that it's okay. Obviously, clinical trials is a totally different beast because a lot of the medicines, and in fact, this is the way our European colleagues get a lot of the drugs they don't have access to is by getting their patients on clinical trials, because then they get access to the drugs for free. But if you're not going on a clinical trial, we work first through the pharmacy and the assistance programs to help the patient so that we can make it something that seems to affordable and that everybody's agree upon. There obviously are some patients where this seems their copay may be unreasonably high. And then we have to, it doesn't happen often, but it does happen. And then we have to decide if that is a blockage to start a particular therapy or not. So we have those conversations. But for most people, we do this behind the scenes before we start therapy.
So Dr. Kittai, I have been diagnosed with CLL, form of cancer. Big, giant, heavy weight on my shoulders. I'm now being led down the path of here's the fancy new medical program, and it's really, really expensive. Add another block to my back right now. Things are getting heavy. I should probably be doing something about that burden that I'm carrying around. How often do you interact with your patients on the mental health aspects of dealing with this disease?
Yeah, so I'm lucky enough that I work with a wonderful team of nurses, nurse practitioners, and we also have a case manager on my team. And so very frequently, and my case manager is a very bubbly personality. And so if she's watching this, she'll probably be laughing right now. But if I'm ever worried about a patient, I do engage, but she actually is just the most bubbliest, nice person and knows all the access things that she can help with. And so I usually ask her to go and talk to them frequently after I'm talking to patients. But certainly, mental health is one of the things that we really should be focusing on, especially for patients with cancer. And in addition to we were talking about telehealth with cancer doctors. Certainly, telehealth with psychologists and psychiatrists is a huge thing these days. And so I think that being open and honest with your physician about how you're feeling. Because another thing just to touch on, and this is just a side note, is that what also causes fatigue? Depression causes fatigue, right?
Absolutely.
And so that is one of the main things I actually screen my patients for when they're complaining of increased fatigue that is disproportionate with the amount of CLL that they might have. And so I think that if you're actively having depressive symptoms, if you're struggling, you need to let your doctors know, because there are things that we can do. And if you do have a good case manager like I do, she can brighten anyone's day. And so, yeah, definitely let your doctor know for sure.
I want to dig a little bit deeper into this because it's such an important aspect. We've used the word depression. What is it? I mean, literally, what is depression?
So there are two screening questions I use for my patients. And the first screening question is, would you describe yourself as being depressed? Because typically someone who has depression has thought about it, right? So it's not something that is not without mind. And then the other question, the other screening question that's been validated is, have you lost interest in the activities that you typically like to do? And so if you answer yes to either of those questions, there's some more screening questions that you can do after. But if you have either of those things, I would seriously consider talking to your doctor. Now, I don't know the medical definition offhand of depression, but in general, it's thoughts of loneliness, thoughts of sadness that don't go away, right? And then obviously the worst form of depression is suicidal ideation. And so I would say that if you have any concerns that you are feeling down and out and it's related to your cancer diagnosis, there are certainly things that we can do. There's certainly programs that we can have our patients go see, psychologists, psychiatrists that can help our patients through this.
That's good information. It's good advice. It's good direction. I know that oftentimes patients believe that there is a stigma associated with depression. And I urge everyone, both here and online, there's no party foul with being depressed. If you are exhibiting any of those symptoms, if you loved playing catch with the dog and that doesn't do anything for you anymore, let your team know. There are a lot of resources available, both traditional medicine and even organizations like betterhelp.com. You can get this stuff online. Sometimes just being able to talk about it is an immense relief. So I encourage you to all be candid with your team about mental health. Next up, Dr. Jackie, we have 3 basic groups in our patient support communities. We have patients who take an active role in their own care. We have patients who just lay there and take it. Let's be honest, they're there. And then we have patients who believe that they can diet and exercise their cancer into oblivion. I worry about my diet and I worry about my exercise, but I'm not doing it to make my cancer go away. I'm doing it because I'm addicted to endorphins, and I admit that freely. Let's talk about diet and exercise. What is the role of diet and exercise in the CLL journey?
So yes, we do have patients who think that there are specific dietary supplements that you can take that, you know, will help cure or treat their CLL. I think the most supplements a patient has come to clinic on was 43. So to date, we have no supplements that cure CLL that I'm aware of. I've read no studies to support that. However, we do encourage patients to eat a healthy diet, which is low in saturated fats. You want to eat the healthy fats such as avocado and grapeseed oil and those type things. So just eating a diet that's really high in fat and carbs, that makes you tired. If you ever eat a diet that's heavy in those things, what do you want to do afterwards? You want to go take a nap, because that in itself will make you fatigued. But I tell patients to eat things that are within reason. Exercise, I talk to people all the time about exercise. And many times their response to me is, well, if I'm already tired, how can I exercise? Believe it or not, when you're tired, just as Jeff said earlier, if you just get up and put one foot in front of the other, if you just walk from down your driveway, maybe to the mailbox and back to the house, that's a form of exercise. So nobody has to go run a marathon or go do 50 laps in the pool every day. But anything that gets you moving and try to get your heart rate up is going to be beneficial towards helping CLL and your overall body health in general. Now, as far as supplements, I know several years ago there was some studies about green tea extract and the benefits of that. But I don't know to date of any patients that were cured from CLL from green tea. So I can't argue against the fact that maybe it may be beneficial, but everything within reason. But when you try, I tell when patients are on therapy, I try to tell them just stop all these supplements because they're not regulated. We don't know exactly what's in them and what quantity of what's in them. So rather than, we don't know what's going to interact with the drugs you're taking for CLL and competes for that pathway of where those drugs are metabolized. So just try to eat healthy, try to drink lots of water. Any patient that comes through our clinic to any of our CLL doctors or teams, there's a constant theme of hydration and water. And so they all know that. They walk in the door telling me how many bottles of water they drank yesterday. But that's important for all of us to stay hydrated. The one thing I want to point out, patients who are on the venetoclax ramp up during that time, we are monitoring tumor-lysis. And so we're monitoring your potassium levels very closely. And so that's not the time to take one potassium supplement and think, well, if one is good, 3 is better. So we will usually tell you to lay off the potassium supplements and things like that during certain times during the ramp up phase. So that's just something that we will probably talk about to some degree each time that you're seen in the clinic area.
Yes, ma'am.
I want to echo what Dr. Jackie's saying. It's not that, I don't want everybody to feel like the docs and the team are nihilists against supplements, because it always comes off that we don't believe in any other alternative medicine strategies. It's that we haven't proven, and to be fair, part of that is maybe a fault of the system. It takes funding to run clinical trials with other alternative medications and things. I remember sometimes some plant-based therapies have actually become cancer therapeutics. So it's not that we don't believe in other therapies. It's just that, what may work for one cancer may not work for another cancer. And when we talk about supplements, we just haven't tested them, in the CLL community, in the CLL space, outside of the trial of the green tea that we could talk about more of. And so it's important that you absolutely should disclose to your physician and team what other alternative medicines you may be taking. People don't want to talk about it. Sometimes they feel that the doctors will get upset but the truth of the matter is that may have an impact on your other organ function, like your liver and kidneys. And so any supplements are drugs too, right? So anything we take in our body has to be processed by your organ function. There may be drug-drug interactions with your other medications. Even medications have nothing to do with your CLL. It could be your cardiac medications or blood thinners. And so it's really important to disclose anything you might be taking or considering taking so that the doctors and teams can talk to you about those agents, the potential downsides and the benefits and so on and so forth. It's not that we don't believe in them. It's just that we haven't shown data and we want to keep you guys safe. And so, it's just a conversation that needs to be held.
So Dr. Wierda, I love a good hamburger.
Me too.
I really love a good burger.
There's a lot of meat in Texas.
Well, we have a question that came in, and this question comes up a lot. So I need to frame it with my love of hamburger. Do CLL patients do better on a plant-based diet versus a meat-based diet?
Not to my knowledge.
You heard it here.
I love a hamburger myself, but I don't eat hamburgers that often because they're not good for you. There's a lot of fat in them, and I don't have CLL, but
So moderation.
some of American diet's not the most.
Moderation.
Yes.
Yeah, moderation is my key word, but the American diet is French fries. I love French fries. I love onion rings. You just can't eat that stuff all the time. It's not good for you, regardless of if you have. It's just common sense. I mean, a lot of it is common sense, but there isn't any diet that's been shown to be beneficial for patients with CLL in particular, plant-based or,
So along those lines, if a CLL patient is in watch and wait or even in treatment, are there any vitamins that they should be consuming, or should they just be focusing on eating good food?
I take a multivitamin every day. I think that's a good thing. Centrum Silver or something that's, a reputable brand. I think there are some things that are helpful in terms of just a regular old multivitamin a day for patients with CLL and for non-CLL patients.
Dr. Kittai, how do you feel about hamburgers and vitamins and all that fun stuff?
Yeah, no, my general recommendation is the same. I usually say something to the extent of patients who are healthier when they start treatment do better, right? So if you come in a healthier state, you're going to do better. And so there really is no food that we typically recommend. And I know a question about alcohol came in as well.
Oh yeah, it's waiting for us right there.
Yeah, no, so once again, it's everything in moderation, right? Like, I think that we don't want, battling cancer is a thing, right? Like that's a hard thing in and of itself, right? And so the more that we tell you all to take away things that you find joy in, make it even harder to battle the cancer, right? So if you like a hamburger not once a day, but if you like a hamburger every once in a while, that's fine, right? If that makes your life happy, that's fine. It's not going to affect anything going on with the CLL. It's just a matter of, keeping everything in moderation, make sure that your health is as best as it can be, because once again, the healthier you are, the better you tolerate therapy.
Yeah, what about alcohol? I've joked around quite a lot about if my doctor over here ever says you have to give up alcohol, I probably will be getting a new doctor. That's the way it is. While we're talking about stuff that we put in our body, I would like for Dr. Lamanna to address what I see thrown out on support forums every single day without fail. Sugar feeds cancer.
Yeah, I've heard.
Is there any, what's going on there? Why do people persist with saying sugar feeds cancer?
Well, I mean, again, it actually goes back to what we were just talking about, the diet, right? So if you're having a lot of sugar in your diet, a lot of carbs, a lot of other things that are not good for your body and how you process things naturally, you're not taking care of your temple. It leads to other medical problems. There is a sense, right? So that people who have diabetes are impaired in terms of healing from their high sugars, right? So impairs their immune system and impairs healing ability. And so again, we don't like a lot of cancer. This is just, again, more intuitive stuff. If you take care of your body and your temple, then you're better able to deal with other medical problems or CLL therapy that goes with the territory because you're better fit and your organ functions better. And so there are a lot of online stuff about how high sugar levels are bad for cancer, not just bad for cancer, they're bad for other medical problems too. And so I think moderation should be the key. I think that's what we're all saying on the panel, is that it's not that you can't have some dietary indiscretions, but it shouldn't be all the time. And so that's where that feeds into. So yeah, I think that you just have moderation in your diet and things that lower your sugar and lower your potential of getting other medical problems are going to be important in how you fight off infections and cancers. So that's where that comes from. It's the
So I
same
should
thing.
call it a dietary indiscretion
Yes.
instead of a snack.
Correct.
Gotcha.
I don't like to take everything away from everybody.
I completely understand. There is a great question that came in. I've had many discussions about this. Dr. Kittai, is there a connection between CLL and cholesterol levels?
So correct me if I'm wrong, but I have not seen any connection between cholesterol levels and CLL levels. I think we kind of touched on this a little earlier, but the bottom line is that, CLL affects mostly patients who are older. And as we get older, we have more difficulty regulating our glucose. We have more difficulty regulating our cholesterol. And that just comes with aging and the American diet, right? And so ultimately, what it comes down to is take care of yourself, take care of your other comorbidities, the C word, and you should do better with therapy. But in general, there's no link between cholesterol and CLL.
Dr. Jackie, all the stuff we've been talking about, the fuel that we're putting in our temple and taking care of the spiritual center of our temple, making sure our mental health is in order. Are there any other tips and tricks you want to share with the audience? I mean, we've got people spread out all over the country and maybe the globe right now. It's time to send a good message home.
As far as diet or anything?
What people are doing to take care of themselves. How important is it for CLL patients and their caregivers to take charge of their bodies, take charge of their lives?
It's very important. We ourselves determine how well we can cope with things. Sometimes our coping mechanisms are not 100%. When you're weighted down with, okay, I have CLL, okay, they say I don't need treatment yet, but so that's in the back of my mind. Maybe the job you had, you're not able to function fully anymore, so maybe you've had to cut back on hours, so now you have financial responsibilities that you have to worry about. Some people are already at retirement age, so now that you're retiring with CLL, you're not bringing in as much income, so you can't always afford to continue to do the things that you were doing. So I talk to patients all the time, and I encourage even outside of CLL patients, if you're having problems coping and you feel like you're just being weighted down, it's okay to talk to someone. When patients come into clinic, as Dr. Kittai alluded to, our patients, all of them are screened when they come in the leukemia clinic. The nurses screen them with this questionnaire every visit. if there's patients who tell us that they're having some problems, some coping or some suicidal ideations, and yes, sometimes patients do, that's an immediate call out for help. So we contact the social worker first and then psychiatry in some cases or psychologists and try to get those patients immediate attention. I tell people who are in the community, you know, if you have somebody that you can confide in and talk to that can help allay some of that anxiety and depression, then do that. Speak to a licensed counselor. There are some times when patients have to go on antidepressants or some anti-anxiety drugs temporarily to get them through that immediate period. But we always want to make sure that people, mental well-being is just as important and sometimes more important than physical well-being. So a patient, they're not going, with their CLL status doesn't matter if they're at a point of wanting to commit suicide. So that's a very key important fact that we have to address and do address. And we encourage patients to always talk to somebody. If they don't talk to you about it, then find someone that they can.
Excellent, excellent advice. Dr. Wierda, you're part of CLL Global, and CLL Global is helping put on this event today. I feel like I would be remiss if I did not channel a part of CLL Global's founder, Dr. Keating. Since you are here in his stead right now, you know that one of his big action items is his patient's mental health. And part of that mental health is how they're getting along with their significant other. So, and I'm going to quote him, let's talk about sex.
Oh. I wasn't expecting that one.
I know you are.
Oh my gosh.
So
My
we're
blushing.
talking about mental health. We are literally going to be moving into how to deal with relationship
I'm
issues
so glad
and
he
how to
asked.
talk to people. So I decided to give you the hardest question there
I
was.
haven't heard anything after you said sex.
Okay.
I'm sorry, start again.
So how important is a CLL patient's sex life? I mean,
I think it's important.
How do we deal with it?
It's important for everyone. I mean, just to back up a little bit, I think something that you said in the very beginning of this really resonated with me, and that was that you have sort of taken account of your priorities in your life, who's important to you, building the relationships with those who are important to you, your family, your friends. And I think you've sort of, that's a special thing. And I think not everybody does that. And I don't think you have to have CLL to do that. I think we all should be doing those types of things. COVID helped a little bit with that, but I think perhaps we should sort of take your advice in that and take account of what are important things to us, our spouse, our relationship with our spouse, and a healthy sex life is very important. I mean, we're all human beings, and that's just, although I blush about it, it's just part of being a human being. So it shouldn't be.
It's part of being a normal human being. So if that part of your life is no longer normal for whatever reason, get some help.
Yeah.
That's what we're talking about here. Whether it's your belly, your brain, or anything else, if it's not working the way you want it to, get some help. So how do we, and this is going to be a toss-up question, how do we talk to family and friends about our CLL diagnosis? There are 1,000,001 different approaches and strategies, and people believe one way is better than the other. I'm going to toss this up, and whoever wants to grab it, please do. What are some strategies for this?
You want me to start? I think first is the comfort level. Each of the patients are different. And so there are some people who first have to get a handle on the diagnosis themselves. And so, usually when I have that conversation, I ask who they want to include on the conversation. Sometimes they're ready to have they're ready to do that. Sometimes they're not. And they're like, I need a little time. But you can't remember everything at one sitting. And so oftentimes I'm like, why don't you bring your family member, your significant other, children, if you want to. We'll talk about children, I think, in a minute. But, if you can't explain it. You can't feed back everything to your family member or your significant other about your new diagnosis when you're hearing half of it most of the time. And so oftentimes I'll say, let's call them on the phone or bring them into your next consultation so I can explain things and if they have questions. Because, right, the significant other is always after you come back from your appointment, what did the doctor say? Don't you remember? What do you remember? Blah, 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 blah. And they're like, I don't remember. I didn't ask that question. I forgot. So the point is how you want to, I think we base it on each patient is different. And so I initially want to ask the patient how they would like to bring other people in the conversation, who they want to share this information to. And then we work on that depending upon each personality that the patients have. When it comes to children, there are, of course, adult children, and then there are little children. And so depending upon how old you are, that conversation can be tailored differently because some people feel they're not ready to share with their extended family or their children or work. I mean, it doesn't have to be family. It could be the work environment. And I think that people need different times that they feel comfortable when they're ready to sort of include others. And I do think that's personal and different for everybody. When they're little children, oftentimes, again, there are actually support groups that we can reach out on their behalf, like CanCare, right? There are different groups that can incorporate how to do that with children. And I often talk to my younger patients with CLL about how they want us to, when they feel ready about talking to the children. Children don't need to hear everything, but children are really savvy. Even little children are really savvy, and they'll get very upset not knowing, because they do know something's going on, and they'll actually be more upset about the fact that they don't feel like they're included. And so often I encourage the patient, if they have little children, to say, hey, let's find a forum to do this, because I think it's important for your child too. Go ahead.
Yes, I was going to say, as a older child with aging parents, one of the things that I've talked to my parents about was there's the concept of like protecting me. Trust me, and I don't know, everyone's a little different, but you're no longer protecting your kids from this diagnosis, right? You want your family to know what you're going through, right? We talked earlier about how you have symptoms that you're dealing with that are difficult to voice, and you have to keep your family and your friends close to you going through this. And at the end of the day, it's your children who are going to wind up being the ones helping you through all this, right? And it's important to let them know if something's going on as soon as possible, in my opinion. And this is like something very personal to me as well, as I'm saying this out loud. But I think this is most likely the case. So I really do encourage all my patients to let their kids know when they get this diagnosis, because ultimately it's important for them to know, it's important for them to help if they can. And be supportive of you going through this process. The whole concept of like protection, because like they're better off not knowing, I think that's a total fallacy.
Yeah. I think there's more hurt involved in that way, with your children by not, retaining that information. And I think for any cancer diagnosis, I think that, would you tell them that you didn't have heart disease, or diabetes, right? It's the same sort of concept. Most people know they're taking medicines. Oh, mom and dad are on insulin. The same thing is I think your children want to know what's going on with you. So if they could be supportive, great. Maybe they'll be supportive in different ways that you never even could have imagined. And so it's, I think, important early on, but everybody does need a little bit of time to sort of sometimes encompass their own diagnosis first, which I get. But I think it's important to include others.
Fantastic. Dr. Broadway.
I just wanted to share that also. It depends on the family dynamics, because in some families, they're not in a position in that type of relationship to share with certain family members. So as she said, I think it comes down to when you talk to that patient, you get a sense, you get a sense over time of, what the family dynamics are. If it's going to be more of a stressor for them to share this with their kids who may not be as supportive, then maybe they shouldn't. So again, it's individualized. You have to look at the family and the family's dynamics and where that patient, what type of relationship they have with family members. But I have a patient I'll never forget. He and his wife thought they were doing the right thing for many years and didn't tell their kids, from small kids until the kids graduated from high school. And when they finally told them, they were very angry for a long time. So I always encourage patients to talk to your kids and be honest with them, if they can.
So I'd like to add something from a bit of a personal perspective. Everyone, like Dr. Jackie said, everyone has a different family dynamic. But for the most part, we have family members that deeply care about us
Mhm.
and are deeply concerned about what's going on. They may not always be able to express it well, and you may not always be able to understand how they're trying to express it. My mother passed away shortly after I was diagnosed with CLL, so it's been more than 13 years. She was dealing with Parkinson's at the time and was not having a really good go of it. It wasn't great. I have the ubiquitous cell phone back there, ring her off, and I have the very last voicemail she ever sent me. And whenever I need a little bit of centering and focus, I literally play that voicemail back. And the first thing I do is giggle because she says, "Hello, Jeff, it's your mother." Of course, I think I'm going to recognize my mother's voice, and there's this thing called caller ID, not a problem. But you could tell that her voice was creaky and she was under duress and strain. But she says, "I need you to call me back. I need an update on your health situation. Love you. Bye." And I can't get rid of that voicemail. That tells me that my family is important to me. I have my youngest daughter in the corner back there. We talk a lot. She asked me to serve as a mentor in her school, and I'm happy to provide that service. When she has problems, she comes to me. I owe her the respect of letting her know what's going on in my world and what I need from her. I do that with her sister, and I do that with her mother. And you know something? It's kind of cool. She's almost 27. My other daughter's 31. I actually like having them come over now and have cocktails. They've become fun human beings, and they weren't always fun human beings. Every Friday night. Folks, it was really, really important for us to have this discussion about mental health and working with your relationships and working with your family, because it is, like I said earlier, this is the important stuff. When you get a CLL diagnosis, you have a unique opportunity in your life. You have the ability to pull up the parking brake instantaneously and decide what it is that's going to be important to you going forward. You can make the personal decision to get rid of the stuff that just doesn't matter. I believe the euphemism these days is you got to determine if the juice is worth the squeeze. There's a lot of times where it's not. CLL gives you an opportunity to stop, figure it out, take care of what's important. We're going to take a short break. We're going to be back here at 1:15. So those of you here, there's facilities just outside. Use your facilities at home. Prepare your questions. The Q&A session is coming next. See you in a few. Welcome back, everybody. Glad you're here. Glad you're enjoying our talk about CLL. I'm going to remind our online audience, hey, when those survey links come up, please make sure you fill out the survey. We really need to hear from you. We need to know what we did well, what we did not so well, and what you'd like to see in future events. Now's the time where we have a Q&A session. We have some questions lined up, both from online already and here in the audience. If you have a question here in the audience, please raise your hand. Wait until you get that microphone. We want to make sure that we actually hear your wonderful voice. So we already have a question lined up. You're on deck.
All right, I have two questions. The first one is about just day-to-day life with CLL. Being on ibrutinib, of course, I can't take, but being on ibrutinib, I can't take ibuprofen or naproxen. And Tylenol is great, but not strong enough for a lot of muscle skeletal pain. And I'm wondering if you have any recommendations.
I will say that you can take naproxen and ibuprofen, just I wouldn't take it all the time, right? So if you're having severe pain, it's okay to take an NSAID every once in a while, but it can increase risk of bleeding, right? And it can affect your kidneys. So we don't want your patients on it long term. There are some, we use like a calcium magnesium phosphate, I think it is, supplement to help with joint pains associated with ibrutinib. You might correct me if I'm wrong. I think it's calcium magnesium phosphate. I always forget. It's a triple pill that sometimes can help with joint pains. You can ask your doctor about. But yeah, I would say that if you're having long-term pain, you should also be evaluated too, right? So I often send my friends, my patients to ortho. And in addition to, if we think the joint pain is the causes the ibrutinib, I have switched to the second generation BTK inhibitors with that as well. And then there are some patients, and I know there's a question about this, that you can dose reduce or do dose holds as well if we think the joint pain is directly related to the BTK inhibitors. So I will say that you can take NSAIDs. We just don't want our patients taking them all the time. That we can consider dose reductions, referral to ortho, and those are a lot of things that we can do to help patients out.
Specifics, like don't take too long. I mean, approximately 2-3 days.
Yeah, I would say like the classic naproxen dosing is 5 days. Yeah, and so I would say so it's a classic dosing is 5 days. I wouldn't take it longer than that. And yeah, if you are finding that you are having to take NSAIDs multiple times a day for multiple days in a row, that's something that you really should let us know about. Yeah.
And then intermittent fasting. Big trend right now. Oh, no, that's- Sure. Intermittent fasting is a big trend. Several of my family members do it. And my son said, if you fast long enough, your body starts to generate stem cells. And I'm just going to go out there and say, could there be any help with our CLL on that, with that?
Not that I'm aware of. So I was, me and we were talking about this the other day, but at the end of the day, you know, diet and exercise is the key. And so oftentimes it's hard to stick with a diet. And so ultimately I tell my patients that choose a diet that works for them. Most diets are good because they limit caloric intake, right? And so if you're trying to stay healthier, it's about maintaining your diet and not eating excessively and doing things excessively. So the key here again is everything in moderation.
And if you're doing fasting, make sure it's okay with your other physicians in case you're on medicines or things where you shouldn't be fasting.
Very important.
Yeah.
Very important.
I also want to say, as far as joint pains and topical Voltaren gel has been shown to show benefit in those patients. It's over the counter. It's no longer a prescription, and I've heard some really positive outcomes with using that topical gel.
Great question. I have one more bit about that because joint pain is a very common complaint on the support groups. A lot of people on CLL support group on Facebook they report that taking a Claritin helps with joint pain. What's going on with that? I've never made the connection.
Yeah, so I mean, the antihistamines in general can sometimes help with sort of the inflammatory response in your body. And so oftentimes even with people who take vaccines and have reactions to vaccines, will often recommend sometimes they take that too, because it might mitigate for some of the, sort of autoimmune inflammatory response that you've seen. And so that sometimes is helpful for joint pain as well, but also reactions to vaccines and other things, or people who get, let's talk about, we didn't even talk about all the skin stuff and the arthropod reactions and the bad bug bites and things like that. But sometimes dampening what your body would be sort of this very hypersensitive immune drive that you have from the CLL, where you get these exaggerated responses to certain medications and bug bites and other things. You can drive that down sometimes with the antihistamines.
And also steroids. So we've given short courses of
Yes,
steroids as
for
well.
and I guess that what he was saying is trying to figure out, is this related to the drug or is this related to you have arthritis too? And then sometimes, figuring that out will then help, the docs figure out how we can best help you with either, certain supportive medicines or other referrals.
And don't be afraid if you get steroids and your white count jumps up. That's a totally normal reaction. So I had one patient who was getting steroid knee injections and didn't tell me. And every single time his white count was going like this. And I was like, what is going on? He's like, and eventually we figured it out. I was like, every single time you get a steroid knee injection within a week of seeing me, your white count's like through the roof. So what the steroids do is they cause the white cells to get higher. It's a normal effect. So don't be worried if you are on steroids for something else, whether it be, a COPD exacerbation, joint pains, whatever it might be, it will cause your white count to go up. It will come down again.
We got a great question in, and I'm going to send this to you, Dr. Bill. Obviously, I have CLL. My uncle has CLL as well. So what's the deal? Is CLL hereditary?
So there's an entity called familial CLL, where there are multiple family members who have a diagnosis of CLL. It's usually first generation or first generation, not first generation, but family members who are directly related, like mothers, fathers, uncles, aunts, brothers, sisters. I guess that's first generation. And so there are multiple family members affected. It's about 10% of patients with CLL who have familial CLL. 90% are what we refer to as sporadic, meaning there's not really any family association with a diagnosis. For a while, we've been interested in understanding what are the risk factors for familial CLL, what's the genetics behind why family members develop CLL. We haven't figured that out yet, but we're interested in it. And that's an area of research. There probably is some gene or genes or genetic basis for that because there are multiple family members affected, but we just haven't figured that out yet.
Is there any group of people or ethnicity that may be more prone to this?
So Northern European descent there's a high incidence of CLL among individuals who are of Northern European descent. There's it's very uncommon in the Japanese population. And those with an Ashkenazi Jew heritage also are at increased risk.
Gotcha.
And sometimes, CLL may not be part of the familial CLL incidence, but there might be a more global issue in the family genetics, meaning a predisposition to cancers in general, which CLL could be one of them, but it could be, I have a family history where there's breast and there's colon cancer and there's leukemia and there's this. So we'll oftentimes ask folks when we first see them a little bit about their family history to see whether or not they should be screened for other genetic familial mutations that might run in the family that might be warranting, genetic screening for other cancers if they have a familial genetic mutations that's not necessarily CLL specific.
Dr. Kittai, you mentioned this earlier. It was a tangent. The idea of reducing dosage or stopping the dosage for a BTK inhibitor. How does that work?
Yeah.
What patients are candidates?
So this is a not controversial, but I don't know if everyone shares this opinion. But now that we have the second generation BTK inhibitors, which have been shown to be safer than ibrutinib, right? I favor the second generation BTK inhibitors when I'm starting patients on BTK inhibitors. So that's number one. Now, the question that a lot of people have been tossing out is, I'm on ibrutinib. We have this other class, newer class of BTK inhibitors that are safer. Should I just switch? I don't typically just switch if someone's tolerating the ibrutinib very well. But if someone has been dose reduced on ibrutinib, or if they're developing symptoms due to the ibrutinib, I do switch. I have a low threshold to switch. So that's one thing to note. So ibrutinib, I don't really mess with dose reductions anymore. I just switch to the second generation BTK inhibitors. Now, in terms of dose reductions on the second generation BTK inhibitors, it really depends. So if I'm just starting out therapy, usually within the first year, I try to maintain the dose as best I can and treat through whatever symptom it might be, whether it might be a course of steroids for joint pains or other sort of things that I might think are associated with the drug. If it's cytopenias, I use Neupogen a lot for venetoclax and things like that. But yeah, in general, we can dose reduce. I try not to do it in the first year, but that's kind of depends. And the reason that is because I'm trying my best to get as good disease control as I can. But that's just an overall sense. But there are exclusions to that. So talk to your provider about when a dose reduction is appropriate for sure. Now, the other question was, I've been on ibrutinib or acalabrutinib or BTK inhibitors for a number of years. Can I just stop? I've done this in one patient, also controversial. And that patient had undetectable minimal residual disease, and she was just fed up with taking her BTK inhibitor. She's still doing well. And we now have some data that shows that that is actually something that maybe we should be considering. So for one, we know that patients who have good disease control on the BTK inhibitors, if they have a toxicity that causes them to stop, it's usually around 2 to 3 years that they can go without therapy. I have also had patients that buck that trend as well. Once again, we give these numbers. These numbers are not absolutes, right? These are all averages and medians. So some people have not 2 to 3 years and some people have much longer, right? But there was actually data presented at IWCLL where they did stop patients of ibrutinib who had good disease control, and they measured the amount of disease that came back over time. And most of those patients, 1 year out of stopping, had totally stable disease. So I think that this is something that is coming. It's not ready for prime time yet. I think in select cases, I would consider it, as I have done, but really talk to your physician about that if that's something that's right for you.
Excellent, excellent guidance. Dr. Broadway, I love this question up here. They ask, I'm afraid to go to restaurants and other crowded places. Should I be worried?
I am.
She said, I am.
Well, so here's the deal. For patients who are on therapy and may be neutropenic, meaning your absolute neutrophil count is low, less than 1.0. Yes, you should have some concern about being out and about, eating at restaurants and so forth. I try to not recommend or even discourage patients from going to these all-you-can-eat buffet things because if you ever just pay attention to what people are doing before they reach for those ladles. So that I strongly discourage them from eating at buffets as I don't myself routinely. But if you're neutropenic, yes, I would recommend that you probably may want to limit your outings and so forth. And that would probably be a time to, maybe pick up something and eat at home or try to avoid being around a crowd of people anyway. In general, if you're well and healthy, you've been vaccinated, going back to the vaccines that we've been talking about. So, just you can't go through life being worried about every little thing every minute, but use caution. So try to avoid areas where people are obviously sick. You might want to avoid being in direct contact with them, but use good hand washing and a lot of common sense.
So what you're saying is my choice for next weekend is not your recommendation. I will be in Austin, Texas, communing with 500,000 of my closest friends for the Formula One Grand Prix. Probably not a good idea for someone who's neutropenic, right?
Not my recommendation.
If I get sick, I'll give you a phone call.
Great.
And he'll say, did you not hear what Jackie said?
This will go back and forth. Dr. Lamanna, are there warning signs for Richter's transformation?
So as we talked about earlier, Richter's transformation, for those who don't know, is transformed from your CLL cells. Sometimes they can change into a more aggressive lymphoma. The most common happens to be what they call a diffuse large B-cell lymphoma, but there are some other transformations that they can occur to different lymphomas as well. Hodgkin's disease, prolymphocytic leukemia. There's some other rarer types, but diffuse large cell lymphoma is the most common. Back in the day when for those of us who gave chemoimmunotherapy, for the younger generations, there was a lot more, patients presented a lot more sick in general. They would have fevers and chills and loss of weight and feeling very unwell. Now that still can happen, but with the targeted therapy, sometimes the transformation can also be more subtle. So not everybody is very ill when they present. Maybe it's just profound fatigue that seems out of proportion to the rest of how they feel. So they might be currently on a drug, a BTK inhibitor or venetoclax, but they're having profound fatigue and we haven't found another reason. That would be a reason for us to look. Sometimes people still get fevers. Sometimes just their LDH, one of the blood tests that we often take on patients when they come to clinic. Sometimes the LDH is just rising. So the presentation is not as classic in my experience, and maybe Bill can talk about it as well, given the history and the length of us being around treating CLL for 20 some odd years. I think that there's a more of a mix now in presentation than when we only had chemoimmunotherapy around and patients were much more sicker. We still have some patients who present very sick, but there's now a little bit of a range in how they present. So weight loss, fever, LDH rising, fatigue. Bill, you want to comment?
Well, I mean, I agree. I don't know that I have much to add to that. I think perhaps a couple other distinctions. Richter's transformation is extremely uncommon among patients with CLL who haven't had treatment. And in that situation, no treatment before and they develop Richter's, it's probably another disease and not something that has arisen from the CLL. And we can cure those patients typically with chemotherapy of their Richter's transformation, not necessarily of their CLL, but of the Richter's transformation. Most of the time, Richter's happens in patients who've had treatment, and it's from the malignant cells and the transformed cells, the aggressive cells, have arisen from the original CLL. In those cases, they're a little bit more they're a lot more resistant to treatments and more difficult to manage. And it's clearly an area of unmet clinical need for us and an area of active research. And I think most of the CLL community is working on collaborating and trying to develop new and more effective treatments for Richter's transformation.
So I've got another question for you. There are patients who get diagnosed with CLL and they're on watch and wait. And watch and wait ends for some of them and they go on to treatment. There are some patients who will be in watch and wait for forever and will never need treatment. How large, what percentage of the population is yeah, you got it, but you're never going to need treatment? And how do those people do? I mean, what's their quality of life?
The ones who never need treatment.
Right.
I think it's exceedingly good. I mean, they still can have infections. They still can have other cancers more commonly than the general population. But in general, the disease isn't growing. It's not causing any problem. They're not getting anemia. Their platelet count's normal. And they live a relatively normal lifespan.
10% of CLL patients?
Oh gosh, in my experience, probably overall, I don't know, I'd be interested to hear what Nicole has to say. Oh, and Adam.
We should
Yeah,
pull this all blindly.
20%,
About
20%,
20%.
Yeah, I was gonna say 20.
20%.
Interesting. I mean, I would have thought that most CLL patients at some point would need treatment. So I'm
Well,
kind
that
of,
is
I'm
the
kind of,
80%, the
Yeah.
3/4. That is most.
well,
Which is
so
why.
it is, I would have thought most being like closer to 100%.
No.
I'm surprised to
No,
hear it's
everybody does.
20% that don't need treatment.
But the counter, I think, is often the way it's described. So when, since most people are picked up, right, diagnosed incidentally in their primary care physician, or if they're getting screening for surgery or mammography, women, very common, they're picked up routinely. The docs will often go, you have CLL, it's okay, you're going to die of something else. Well, the truth of the fact is that the majority of patients do need therapy for their CLL. So it's not, the benign disease that everybody talks about when you hear it from their other doctors going, don't worry about it. It's a small percentage of patients who don't need treatment. The majority do. And so I just help, that's actually one of the first things I talk about when I see somebody with a new diagnosis, is sort of counseling them about 20% probably don't need, likely don't need treatment, but the majority at some point do. And I'd rather you think that you might be one of those. We can talk about the ones that we think are in that 20% group, but that doesn't mean we have a perfect test that identifies them. And so even if you're good risk, doesn't mean, I wish I could say that they never need treatment, but that's not the case. So
Very cool. Yes, sir.
And to add on that, like one of the questions on here is they asked, what is the average age of death of CLL patients? And so I touched on this a little bit earlier. And there was actually an interesting study that was presented at IWCLL that looked at all patients who were treated on modern day clinical trials. So these are patients who required treatment. And they did a study where they took all these patients and they matched them to age-matched controls in the general population. And the overall survival of the two groups was practically equal. So with treatment, patients were getting very, very close to the life expectancy. So with treatment, the life expectancy was, and remember, this is all clinical trials, right? So I don't want to, it's going to seem a little bit low, but I don't want you to worry. So this was, it was 52 to 55 months versus age-matched controls, which was 56 months. So once again, it was age-matched controls, right? So they matched the population to age-matched controls to general society, and the difference was only by a few months. And so that just tells us that our patients with CLL are living very close to the normal life expectancy, even if they require treatment with our new therapies, which is a great news.
Again, I think you have to factor in the age component to that.
Exactly.
So
Yeah.
And as I said before, I think for patients over 65, 70, we're achieving probably a similar survival as the non-affected age matched controls in the population. My challenge, I think this group tends to see patients who are younger because we're at academic centers, referral centers. So we see young patients. I have a 17-year-old with CLL that I'm treating now. The lifespan for that patient, even though we have great treatments, we need a curative treatment for that patient. Perhaps stem cell transplant, or hopefully it will be something coming soon, but the life expectancy for a 17-year-old is going to be different, obviously, for an 80-year-old to live a normal lifespan. And so you have to take that into consideration also.
That's an astonishing bit of information. I had never heard of a CLL patient that young. So that was
unusual, but rare.
that was astonishing.
Can I give you one more astonishing thing I've seen?
Sure.
So there's always astonishing things. I've seen someone go into a remission without any treatment. So I've seen a patient go into spontaneous remission. So that, I mean, my point is to be hopeful, right? Like I was just trying to give you a contrast to the 17-year-old, right? But so that can happen, right? So
Interesting.
Right, you have
Hold on, let's get a microphone right up here.
a bunch.
Just a moment. She's coming.
Dr. Wierda just mentioned stem cell transplants, and I was wondering what work is being done in that area because my daughter has preserved and frozen both of my grandchildren's stem cells, and I was just curious as to what's being done in that area.
Not a lot, because we're not using it as much as we used to. I think in the last 2 years, I've probably sent 2 patients for stem cell transplant. So thankfully, we're not having to utilize it as often as we used to when we were using chemotherapy. I think CAR Ts we're much more enthusiastic and interested in CAR Ts. There is research work with cord blood derived CAR NK cells. So those are cell-based strategies that may ultimately take over the allogeneic stem cell transplant, where you've got a donor that you're doing a transplant with.
Very good. We have covered a ton of information. I mean, this has been great. I love having these sessions. They fill me with hope in a wonderful way. And it helps me get my message out to people that you absolutely can live a great life with CLL. Before we go, I like to do the wrap up. I want each of you to tell everyone here in the room and everybody online, what's that one message you want them to hear loud and clear that you could not say a decade ago? I'll start with you, Dr. Bill.
Oh, my goodness. That we couldn't say a decade ago. I think your life expectancy, a cure is soon to come. So we couldn't have said that probably 10 years ago. I remember going to a meeting, and I won't name any names, but somebody brought up the word cure. And it was a group that we were collaborating with, a CLL research group. And one of my colleagues just sort of was like, how can you say that? We're nowhere near a cure. That's not something we even need to talk about. And I thought about it at the time and reflected on it. And it was in the days before we had ibrutinib or venetoclax. And that sort of comment today would not at all resonate with anybody, because I do think we have the tools to cure patients with CLL, and cure is on the near-term horizon for us. And we just need to figure out how to use the drugs that we have available now and optimize them to cure patients. And then the issues of Richter should subside and go away. The issues of refractory disease should go away. And I think ultimately, and hopefully in the distant or not too distant future, the stress and concern about watch and wait will go away, because we'll be talking about curing patients with well-tolerated treatment, and watch and wait will be a thing of the past.
I'm smiling at that.
Oh,
You're on deck.
That's a tough one to follow.
Yes, it is.
Yeah, I mean, I think these targeted therapies really, I mean, I know you guys have heard this 100 times. They really have transformed the way we care for you all. And so I agree with Bill. I think we need to figure out ways to tweak the therapies. Although, again, we have a whole bunch of new players coming in the mix, and I think that will impact for many patients who have relapsed on both the BTKs and venetoclax. I think that there's a lot of good hope for the relapse population as well. I do think that we will need to still, there's a lot of work needs to be done. I think despite these therapies, I still think we have to figure out ways to improve people's immune system. Because of these therapies, there's still a lot of side effects and infectious complications that we need to work on. But I think there's a lot to be hopeful for. It is definitely different from when Bill and I started compared to this one, because we started in the era, not in a bad way, but the next generation has to take over. Okay. But, the good news is that, from where we came from with chemoimmunotherapy and the side effects and the issues we used to see and the limitations, there's going to be a lot more personalization of some of these medications with different subgroups of characteristics of patients within CLL. And so I think there's a lot to be hopeful for.
Yeah, I mean, I said it earlier, but at the end of the day, we're now in an era where we take a pill a day to keep our cancer away. And we couldn't have said that 10 years ago, right? And not only are these pills effective, but they're getting safer and safer and safer. And so I think that is a really exciting thing for our patients with CLL.
Dr. Jackie.
I want to focus a little on the patients who are in the watch and win category. I want you to think of the analogy of an elephant at the circus. The elephant is the center of all the animals, and they're the largest animal. But there are also other smaller animals that are around the elephant that need to be taken care of. So when you are focused and totally tunnel visioned into your CLL, I want you to think about your blood pressure, your weight, your diet, and all of these things that you need to maintain a healthy lifestyle and to continue to thrive in every aspect of your life. so that you're not so consumed with feeding the large animal, the elephant, but all of the animals need to be fed and cared for. With that being said, I 100% concur with everything that's been said about. I'm really excited about the future of CLL for you, and can't wait to see what's next.
Wow. I want to thank each of you. I know that it's a big ask to spend a big chunk of your Saturday, and well, not all of us missed the eclipse. You got to see that. Thanks.
I have a picture if you want to.
It's important for everyone in the CLL universe to know that progress is being made. And I leave these presentations hopeful that we are making progress and that the future is indeed bright. I would like to do a few more things. I would like to thank CLL Global Research Foundation for putting money in the pipeline, putting effort and resources in the pipeline to find a cure for me. I take this personally. I'd like to thank MD Anderson for taking great care of me and taking great care to make sure all of you have a venue to witness these things. I'd like to thank CanCare for providing shoulders for me to lean on and shoulders for anyone that has a need to get matched one-on-one. I'd like to thank CLL Society. Dr. Kaufman is providing wonderful resources all across the globe for anyone that asks. These are great people. I'd like to thank LLS for being another shoulder to lean on. Light the night, let those balloons go, make sure everybody knows that we're going to kick leukemia's butt. I would also like to thank our sponsors, AbbVie and BeiGene. Most of you know this already. When companies like AbbVie and BeiGene sponsor events like this, they do it with absolutely zero editorial control whatsoever. They know that these types of interactions are not just important for the CLL community, they are crucial for the CLL community. They want the words to get out. Lastly, sign up for that newsletter. I really want you to sign up for the newsletter. It's how we keep in touch with you. thepatientstory.com/CLL, thepatientstory.com/newsletter. That's where all the wonderful content exists. And you know I'm going to do this one more time. All of you have that yellow sheet of paper here. That's the survey. Please make sure you fill out the survey. Online participants, you've got a survey coming too. Again, it is the only way we know that we're doing the job correctly. And if we need to make mistakes corrected, we're going to do that for you. I look forward to the next event that we do. I hope that all of you take something away from this, and that something should be, there is hope. There's another four-letter word, that cure word that he used. This is important to me. This is part of my well-being. I put a lot of work and a lot of effort into doing this. The juice is absolutely worth the squeeze for me. Thank you very much. Thank you to our doctors. Thank you to our staff who's been making all the AV stuff work. Thank you to the patient story for making all of us look good. I wish you well. Go live a great life.
Here, here.
And remember,